Welcome back to ADHDKC Conversations. I'm Dr. Kristen Stuppy, and I'm here with my co-host, Sara, Whelan.
Everyone, we're so glad you're joining us. Each month, we sit down with experts, parents, and individuals in the ADHD community to explore topics that make a big difference for our families in Kansas City and even beyond Kansas City.
And today, we're thrilled to welcome Dr. Matt Lindquist. Dr. Lindquist is a triple board certified physician in internal medicine, pediatrics, and obesity medicine, and is the founder of MoKan Weight Loss and Metabolic Health. He's deeply passionate about teaching both patients and medical professionals about obesity as a disease and helping people find individualized paths to better health and well-being.
We're especially excited to talk with Dr. Lindquist today because his work really sits at the intersection that isn't discussed nearly enough. How ADHD, weight, sleep, anxiety, and eating behaviors can all really be connected at a neurobiological level.
This conversation is a chance to get to know Dr. Lindquist, learn from his clinical experience, and start unpacking why these connections matter so much for individuals and families affected by ADHD. So, with that, Dr. Lindquist, you're triple board certified in internal medicine, pediatrics, and obesity medicine, which is a pretty unique combination. Can you walk us through your professional journey and what led you to focus your career on obesity and metabolic health?
Yeah, glad to. And first, happy to be here. Appreciate you having me on the podcast and getting educated. I love talking about this and getting reliable info out there to the public. So yeah, I mean, I'm a true masochist, both in my training and day to day. That fits, and like most of us in medicine, I love to learn, and if I have like a vice, apparently that's it. But yeah, I feel like I had kind of this slow burn into obesity. I knew from a pretty early age. I mean, one of my best friends said, wanted to be a physician earlier than I thought I wanted to be, apparently. And then, I remember seeing there were a couple of docs from small town North Dakota. And I remember during college coming back and seeing my eye doc and one of my friends' dads, who's a family doc in town. I talked to them and one of them didn't even want to retire because part of it was that's their social, aspect of their life too. And that really clicked with me in that, I really love developing those longitudinal relationships and with internal medicine and pediatrics, similar to family med, I get to know that whole family and really see multiple generations. So whereas when I'd go in the OR during surgery, I hated it. I'm cut and run, and no, patients are asleep. Some people love that, and I wanted to see them out throughout their life. And then and this is kind of odd, and I sometimes bring this up in clinic, but I was always just this skinny little fart, maybe 130 pounds soaking wet. So I remember in high school, I was actually I got into nutrition to kind of gain muscle and strength for sports, and that was I think that was when I really dipped my toes into just understanding nutrition, which unfortunately is not taught quite that well in both undergraduate and graduate medical education. So it's probably a little ahead of the curve there. And then I think that just kind of snowballed on itself until I was about a second year resident in my so in my combined internal medicine pediatrics residency, and I spent a month with my mentor, Dr. Brooke Sweeney at Children's Mercy, Dr. Sara Hample, who's the mother of the program, and that's where I saw what that light bulb went off. I saw what good obesity medicine could be, and that was off to the races from there.
Yeah, as a pediatrician, there's a saying that we gave up our 20s for this because there's so much of training that we really do have to give up part of our life to intensely study and be at the hospital and everything. And I cannot imagine being triple board certified. I only did one with the kids. So, but you can tell, if this is your passion, and even since high school, if you had this love of the nutrition, that very much fits how that could keep you motivated to do all that you do. That's fantastic.
Yeah, I think it stands out too. It's rare today to find a family, to find a resource who has so many different layers and levels of your experience, but just interest too, in terms of like looking at things from a family system, which is really so relevant and important with ADHD and with families. You've helped build large academic programs and then went on to open MoKan weight loss and metabolic health. What gaps were you seeing in care that made you realize something different was needed, and for you to go ahead and open your own practice?
Yeah, I mean, first, I mean, it's as some may know, it's a pretty big leap to go from employed practice to kind of bootstrapping your own clinic. So I would say one of the biggest gaps was just my family time, and so that was a major push. But yeah, so I had I had started the University Health weight management clinic, and that was about 8 years ago or so now, and I was seeing people with like heart failure, kidney failure, dialysis, pretty advanced disease states, and I was sitting there in a 20-minute slot, which is inappropriate for them anyways, let alone anyone pretty much. And I was doing absolutely fundamental nutrition stuff, for example. Talking about like, hey, so what is a protein? While also managing these meds and, okay, well, if you're on dialysis, you have to worry about how it's metabolized, by the kidney, a little bit more complex medicine stuff. And even fighting for a dietitian and a psychologist and a sleep psychologist, like, still those resources were still so limited, and I was having to do so much of that, and we couldn't scale. And so I really wanted to do something where I could really reach more people. And then I wanted to see families. Maybe 5% of my practice I was like trying to coordinate between the pediatric hospital and my adult clinic, but it just wasn't wasn't very easy to do. Yeah, so it was just not easy to coordinate care between the two hospital systems for the parents and their kids, and also something I was pretty passionate about, and I knew there wasn't really a resource in town. So that's been really fun to be able to see families in my clinic now, see them back-to-back appointments. It's more convenient for them. And the other, and actually what I did not realize was such a gap, and this is partly just potentially a local or regional gap, was for kids with more like class 1, class 2 obesity. I think class 1, class 2, class 3, or quote unquote morbid obesity. It's kind of the how we think about them. So when I was at the peds hospital, I see a lot of class 3, and they're just bad, really tough genetics, and just really advanced disease states. And then we have kind of a bread and butter nutrition clinic, if you will. And what I started seeing when I opened MoKan was all these kids with, they've got kind of tough genetics, as far as their risk for obesity and maybe diabetes, but they had pretty good resources. And, and their parents were thoughtful about their diets and exercise and sleep, and so they're getting all the things, but they still had a genetic disease, and they really just needed, a lot of times, pretty simple, appropriate meds, and easy to take care of them, and so rewarding to see, like a 15-year-old kid with metabolic syndrome, which we know is a risk factor right now for, heart disease and whatnot down the road. And within a year or so, with pretty simple treatment, it's gone. And they feel great, and the parents are just relieved that they don't have to worry about their kids' health.
There's a lot of stigma with weight and obesity, but also a lot of evidence-based approaches that address the biological, behavioral, and environmental factors of weight management. And you just mentioned genetics several times in there. How do you incorporate the genetic considerations, medications, lifestyle changes into a comprehensive treatment plan?
Yeah, it's a great question. So first, I always get a good picture of the family history. I mean, obesity is one of the most heritable diseases in all of medicine. Historically, we have not approached it that way. And, and one thing, a lot of patients and families, they come to me looking for answers, like, hey, why is this a problem for me? And at least like half the time, it's right there in their initial questionnaire. It's like, oh, okay, well, I ask, who else in the family has obesity? It's like, okay, and they're like, everyone. I go, okay, well, we can stop thinking about that question because you just answered it. I was just talking to a family or patient about this morning, that I find it's fascinating that if we have a family with breast cancer, right, we call that a BRCA mutation, right? A bunch of autoimmune disorders that might be HLA-B27, it's like genetic predisposition. If you have a whole family with obesity, they're called lazy. So like there's this huge discrepancy, but we've known for a long time that it's a strong genetic disease. So one, I like to paint that picture for families, and man, the relief that they get knowing that, yeah, this is not our fault. It's I don't know. I get mad with my staff. I always have, if we're low on or if we're out of a Kleenex in my exam rooms, because there's a lot of tears are shed. Just giving that validation.
There's so much guilt associated with it because people feel like they did something wrong. They ate the wrong things, or they didn't exercise. They are lazy. They feel like they are responsible for their own weight problems.
Right. Well, I mean, that's the message they've been given for, pretty much all of our history so far.
Right.
Many people don't automatically connect ADHD with weight or metabolic health. When did you start noticing in your work a meaningful overlap between ADHD and obesity?
Yeah, that was definitely when I was at the Metabolic Bariatric Clinic at Children's Mercy with a great clinical psychologist that some of you may know, Dr. Amy Beck, who has worked with ADHDKC in the past and has gladly joined the staff here at MoKan. But she was, it was just really helpful, having her to identify and really clarify kind of the behavioral health conditions for our families and patients, and then helping me and the other doc in the clinic kind of come up with, really good medication plans based on this. And kind of over time, we were, one academic center in that particular clinic, we just had more layers of those resources. So I could see it follow, like, okay, yep, hey, we got the formal diagnosis of ADHD. And then, over time, it just that ADHD became so obvious, with certain families and in certain behaviors that either were a major driver for their obesity and weight gain, and or were just a barrier to success in the program. And as you guys know, just life in general. Yeah, so it just is, just time in that clinic with Dr. Beck and how, seeing how it drove the disease and then kind of worsened or limited our success.
Yeah. I think we were talking about stigma earlier, and there's with obesity, well, also with ADHD in terms of control and feeling like, well, just change your behavior. So helpful then that you kind of have your eye on and understand it from a different framework for families to really, like you were saying, to validate and provide some real quality information, but also just support that typically they may not get just from society, So yeah, really helpful.
Yeah, this is I feel like another disease state, if you will. A lot of patients and families get labeled as like lazy, and they come in, they're like self-labeling,
right?
Or someone else mentions that, and I can't remember. It was some years ago that I go, okay, I don't believe in lazy or anything in that realm. Like, to me, it's either some undiagnosed mental health condition, whether like depression, anxiety, or ADHD, or a sleep disorder, like. But yeah, that's just misunderstood. And in the context of some of our old, how we used to approach, anxiety and depression, especially in primary care, it's like, well, just make yourself happier or, whatever. And then we learn like, okay, well, that's not quite right. It's like, oh, be more focused. Like, Great. Thanks for the guidance.
We'll
How about let's change my biology, please?
Right. When we talk about ADHD, we often focus on the attention or the behaviors, but not always what's really happening in the brain. And ADHD is associated with a shortened lifespan because of many factors. But can you talk a little bit about the shared neurobiology between ADHD and obesity, which is, of course, one of the relations to the shortened lifespan?
Yeah, there was a great study or just like review published years ago by Dr. O'Hara out in Maine, kind of prominent pediatric obesity doc. And this is kind of a light bulb moment for me thinking about this, because one, Dr. Stuppy, as you know, when we see, so as pediatricians, we see like eczema and asthma and allergies, we know like these are like really shared things, and they're in this like grouping where if you see one of them, you're likely to see its friends. That doesn't mean they have to be there, but they're generally lurking around somewhere. And this really shone a light on that for me. And what we know about it is it's the link between the two is primarily like dysfunction in our like dopamine and like reward pathways. Right. So there's a little bit more to that, but that's kind of the main center where we have some trouble. And in fact, so there's some functional MRI studies. And so for you folks out there that don't know what that is, we look at the MRI, it's like the, 4K TV where an X-ray was like, TV sets of the 1960s. So really detailed view of, in this case, our brain. And then the functional is like, actually, you're doing something, like you're looking at cards or watching something. So we're looking at changes in your brain while you're doing something. And what we've seen with this overlap of ADHD and obesity is like three kind of specific areas. One is like reward processing. And this is actually, so part of this is like food responsiveness. Okay, so you like seafood, not shrimp, but you visualize it. And is your brain kind of lighten up, or you're like, I'm fine? So that accounts for about 64% of the effect of between ADHD and our fat mass. And then two is response inhibition, right? So like, okay, again, like I see this, or we drive by one of the 1,000 billboards that tell you you're hungry, and then I want it, and I know it's not great for my health or like my goals, whatever, but I got to have it anyways. Or like the hyperfixation, right, with ADHD, et cetera. It's just a wonderful, terrible combination. And then, and the third part is just emotional regulation. And I see that clinically a lot with just like emotional eating. So, yeah, so those are the kind of the main shared pathways between the two, and that we see, I see pretty regularly in clinic.
You also work with patients who have anxiety, binge eating, and sleep disorders. How do you see these issues interacting with ADHD in your patients?
Oh man, like I said before, it's they're close friends. So one, anxiety is the most commonly associated like behavioral health diagnosis associated with binge eating, which I think a lot of people don't know is the most common eating disorder there is. And depending on your setting with like a bariatric surgery center versus, an outpatient clinic like mine, I mean, we can see 50% of people coming in with somewhere on that like binge eating disorder spectrum, up to like 75% if you're like in bariatric surgery. And a big part of this, again, that reward pathway, right? So dopamine, reward. But then, of course, people with ADHD that have more like impulse control issues, which particularly is more prevalent in kids. And so it can, so that part of it, thankfully, lessens a little bit over time. But especially with kids, impulse control is huge. And then, as you guys know, ADHD can worsen the anxiety, or the anxiety can worsen the ADHD, and then both of those can kind of swell into this risk for binge eating disorder later. And then sleep disorders, which are one of the most important things that we think about in obesity and just our metabolic health long term. It's it's a huge risk for these patients. One, insomnia, so trouble falling asleep, that can be due to kind of circadian rhythm problems, or anxiety. One of our patients are like, hey, my mind is just racing at night. I'm worried. And that could be either anxiety and or ADHD. And then when you have sleep disorder and poor either quantity or quality of sleep, that can worsen the inattention or anxiety symptoms. And then, and it's like this snowball of not goodness.
Right. They all like to play together, which is not healthy for us.
Not great. Yeah. It's like the troublesome kids on the block, and they just hang out together. And when one of them gets wild, the other two get like even more turned up. It's rough.
Yeah.
You've emphasized genetics and individualized treatment in your work. Why is having a personalized approach especially important when ADHD is part of the picture?
Yeah, it's a great question. So, one, I like to think about treatment over a long term. And so I can teach a monkey how to help someone get, 15, 20 pound weight loss in 6 months. Like that's, anyone with ill intentions and a strip pad can probably accomplish that these days. But one, we've known for years that if you find the right treatment for the right person, and kind of what we call like a phenotype. And so, in this setting, I often worry about that kind of, hedonic eating. So like more like emotional / binge eating, again, oftentimes associated with like ADHD or anxiety. They're going to respond much better to certain medications. And then, if you're ignoring ADHD, then okay, if you're not having great effects with your treatment, like okay, are you forgetting your meds? Do you have troubles like planning the meals that we talked about, or are you just like, oh man, I forgot breakfast and lunch, and now it's like it's just appetite's off the rails in the evening and I binge. So it's really important to get to those like fundamental things that are a barrier to you just taking care of your health. Because really the weight loss often is so, I wouldn't say easy. The challenge is really like, how do we guide you to just have a healthy, happy life? Like that's what I'm trying to get for or aim for my patients. And yeah, you just can't ignore something such a foundational like ADHD.
Yeah. There's a lot of confusion and fear around medications, both for ADHD, weight management, and other things that have a lot of stigma attached to them. So how do you help patients think about the pharmacotherapy for obesity in a thoughtful and evidence-based way?
Yeah, great question. So, one, I think we have to do it. It just humbly it would be the first answer. So, and this kind of goes back to just understanding the genetics and the biology of all this. And so, as you all know, ADHD often doesn't come out of nowhere. That's, we find that somewhere in the family. And obesity is very similar. And so, I'd like to, one, just, tie in that context. And then I always ask about like, what are your goals? What are your goals in life? Like, what are your goals for your health and life? And oftentimes that's, by this time they're seeing me for a reason. And this is not about like you're a failure or you can't do it on your own. It's just some disease states we need medications to have our healthiest life. And we have, a lot of evidence with these medications, a lot of evidence of what happens if you don't do them. So, I just like to just paint that picture that it's not, this is there for you, the goals that you told me about before I even met you, in your questionnaire. And it's not a failure. It'd be like if you had cancer or diabetes, like we wouldn't question like, oh, why are you on meds? Like, well, yeah, I've got a disease that can cause problems. These are not, they're different, but not that dramatically.
So yeah, so helpful. And I know that for parents who may be listening, there are some light bulbs going off or going, this explains a lot about their own child, or even, like we said, families, it's genetic themselves. What's one shift in mindset or how they look at things that you hope that they can take away from our conversation today?
Ooh, yeah. I think one that again, this is biologically based. Both, ADHD, anxiety, obesity. Does that mean you can't control it? No. There are a lot of things we can do to help all of them, but also some people just need treatment. And ideally someone that knows the disease state. You get evidence-based experience guidance, because they're nuanced and they're kind of difficult too.
I think that'd be really so helpful in creating some hope for families, but also confidence, having a reliable, well-educated, knowledgeable physician, right, to get guidance from. So it can be hard to know where to go.
Not everyone has a Dr. Stuppy as their pediatrician.
Right.
And I do not do this. I've actually referred patients to you because it's well outside my scope of practice. We all have to stay in our lanes. But I am very excited that you're speaking with the ADHDKC parent group, because I do think this is something that is very common, but not talked about. Again, this obesity medicine has even more stigma than ADHD. ADHD in some realms, there's almost people want to be neurodivergent because it's kind of that catchphrase right now. It's kind of
cool. For sure.
Du jour.
But nobody wants to be unhealthy. So I'm very glad that you're going to be speaking to our parent group on Tuesday, April 14th at 6:30 online Central Time. And without giving too much away, what are you most excited for parents to understand after hearing your talk? Wired, Tired, and Hungry: How the ADHD Brain Impacts Weight, Sleep, and Binge Eating.
Man, I feel like the title, does it. That's what I'm excited about. No, man, when I mention that to families in clinic, it's like, oh, the light bulb goes off. They're like, I feel like you saw right through me. I think kind of painting that full picture of those unfortunate friends, and how we can address them. And identify any things that are making potentially all of them worse at the same time. So, looking forward to it.
Too. Thank you so much for joining us today and for helping really bring clarity to a topic that's often so overlooked.
Yeah,
pleasure being here.
Really looking forward to this conversation. Again, if you are interested, go to ADHDKC.org and hit the events tab to learn more and sign up. It's free, and it will be on Tuesday, April 14th at 6:30 p.m. Central.
All right. Thanks for having me.
Thank you.